Okay, thank you. Good morning, everybody. We'll start today's morning session, which was supposed to be chaired by myself and Dr. Bill Noel. Unfortunately, Bill is unwell at the moment, and I'll be chairing the session today. I'm Madhuri Pandey, Chief of Pediatric Cardiac Surgery from India, basically. So without much delay, we will start with our second presentation because I've been informed that the first presenter, Mr. Papake, has not joined us. So, good morning, Dr. Milovanovic. Hello.
How can you hear me?
Hello, can you hear me?
Yes, I can hear you perfectly well. I hope you hear me too.
Yeah. Would you kindly start your presentation, please?
Okay, so I can start with the presentation, yeah?
Yes, thank you very much. Thank you.
Okay. First of all, greetings from Belgrade. My name is Vladimir Milovanovic, and I'm head of the Department of Pediatric Cardiac Surgery in Tiršova Klinika in Belgrade. It's a privilege for me to participate in Global Forum Eurasian Symposium of Pediatric Cardiology and Cardiac Surgery. And I would like to thank Kalangas Foundation for giving me an opportunity to share my view on the current situation in pediatric cardiac surgery in Serbia. On the beginning, some historical facts. First steps in pediatric cardiac surgery in former Yugoslavia were made in Institute for Mother and Child in Belgrade. First coarctation repair was done in 1966. Took place in this hospital. Also, first department of pediatric cardiac surgery was established in this hospital in 1972. And in the next 10 years, some 100 patients with congenital heart defects were operated without cardiopulmonary bypass. First ASD repair was done in 1982, and afterwards, pediatric cardiac surgery program continues to evolve. Former Yugoslavia was a much bigger country than present Serbia. The population was around 21 million. In the 80s, there were two pediatric cardiac centers, one in Ljubljana, Slovenia, and the biggest one in Belgrade, the Institute for Mother and Child. Belgrade Center in this decade operated annually around 350 operations. In 1986, the first cardiac surgeon was trained for 1.5 years in Great Ormond Street Hospital in London, UK. And also at the end of this decade, first arterial switches for DTGAs were performed in Belgrade. With the 90s came the horror of war, sanctions, breakdown of Yugoslavia, and bombardment of Serbia. During those grim years, pediatric cardiac surgery program was barely alive. Nevertheless, two more surgeons this period were trained also in London, in Great Ormond Street Hospital. Very important role in keeping the program alive, and Mr. William B. Novik and his International Heart Foundation. Throughout 4 years, he operated on almost 90 patients and left a deep mark in education of staff in Belgrade. In 1999, during the beginning of Serbian bombardment, he was in the operation theater doing the switch procedure for DTGA, and that child she's a grown-up person now, is very well and fine. During the first decade of the second millennium, 3 more pediatric cardiac surgeons were trained, also in Great Ormond Street Hospital. In the 1998s, there was a new department of pediatric cardiac surgery in Tiršova Clinic. This is the largest pediatric cardiac center now in Serbia and former Yugoslavia region, with annually 250 operations. As I mentioned, also the continuous education of surgeons, cardiac surgeons, was also in this period. 2 of them were trained in London. So what is the current situation? Now we have two pediatric cardiac centers in Serbia, one in Tiršova, other in the Institute for Mother and Child. Tiršova is the biggest one with 250 cases, 250 operations annually. Institute is having around 150. Currently, there are 4 surgeons and 2 trainees. The patients that are referred, of course, from Serbia, but also from Montenegro, Bosnia and Herzegovina, and Republika Srpska, predominantly from Bosnia. Overall population of this region is around 8,050,000. In Serbia, annually, we have around 63,000 newborns. With Montenegro and Republika Srpska, it's annually around 18,000 newborns. So basically, these are the pictures of our teachers and people that kept program of pediatric cardiac surgery alive during last 30 years. They're the ones who are responsible for our enormous progress that has been made, especially in the last 20 years. In the middle, we have Dr. George Herzog, who is a pioneer in the field of pediatric cardiac surgery in former Yugoslavia, also in Serbia. He's now 6 years in retirement. Mila Stajević and Slobodan Ilić are still working, but they are nevertheless slowly beginning bring their professional career to the end. Slobodan used to be the chief of the Department of Pediatric Cardiac Surgery at Tiršova Clinic for more than 20 years, and Mila Stajević is still head of the department in the Institute for Mother and Child. So how do we have patients referred? We have almost 100 pediatric cardiologists in the regional hospitals and centers in Serbia, Bosnia and Herzegovina, and Montenegro. Practically 80% of them are trained in Tiršova Clinic. We have also trained neonatologists who are also cardiologists in the most large maternity hospitals in Serbia, Montenegro, and Republika Srpska. Basically, patients are referred from the regional cardiologist to the cardiology department of Tiršova Institute of Mother and Child. And then we have every 2 weeks joint cardiac surgery sessions. Afterwards, patients are placed on the waiting list for surgery. What is the situation with prenatal diagnosis? We estimate that around 25% of severe congenital anomalies are diagnosed prenatally. We have a relatively small percentage of aborted pregnancies. For example, hypoplastic left hearts, we have 5 to 6 referred annually on 63,000 deliveries in Serbia. And we didn't notice any decline of number of patients that are referred for palliative treatment for univentricular heart physiology. As for the preoperative diagnosis, we have 14 cardiologists that are trained and fully dedicated to cardiology in Tiršova and Institute for Mother and Child. We have 6 of them trained in diagnostic or interventional catheterization. In Tiršova, we are doing around 300 catheterization annually, and of them 150 are interventional. We have also 5 cardiologists that are trained for nuclear magnetic resonance in patients with congenital heart disease. Unfortunately, we notice a significant shortage of radiologists that are trained for a computer tomography in patients with congenital heart disease. As for the facilities of the Department of Pediatric Cardiac Surgery, in Tiršova we have cardiac intensive care unit with 6 beds. In Institute for Mother and Child, there is a intensive care with 5 beds. In every hospital, we have 1 operation theater and 1 catheterization lab. We have 5 trained cardiac anesthetists and intensivists. And for the on-call regime, we involve intensivists, anesthetists, cardiologists, and surgeons. Of course, like in most other societies, we have permanent shortage of qualified nurses. So what is the current situation and current practice of pediatric pediatric cardiac surgery. We have routine surgical treatment of most common congenital heart defects with excellent results. We're doing ASDs, VSDs on a regular basis. AVSDs are operated up to 6 months of age. We have routine surgical treatment for premature babies with ductal arteriosis persistence. Most of the patients with coarctation are operated within 3 months of age. We are doing also routine surgery for interrupted aortic arch pathologies of follow are operated up to 1 year of age at most. We're also dealing with pulmonary atresia with VSDs, but without NAPCAS. And also we have a routine treatment for patients with total anomalous pulmonary venous connection. For decades now, we have a standardized treatment for patients with univentricular heart physiology, starting from pulmonary artery bending or modified Bailey shunt till Glenn procedure or Fontaine procedure. Most of the patients complete their Fontaine treatment up till 4 to 5 years of age. We have also standardized treatment for patients with the truncus arteriosus and other common truncal anomalies. Unfortunately, we don't have a homograph bank, so most of these patients are treated using Contegra, ZRB2PA conduit. It's been more than 20 years now that we have experience with arterial switch operation for DTGA with more than good results. Average mortality is below 3%. We have more than 10 years experience of doing a normal procedure for plastic left heart syndrome. For the newborns with congenital aortic stenosis, the initial treatment of choice is interventional catheterization and balloon dilatation. So most of the patients are first referred for the treatment by cardiologist. Nevertheless, if they need surgical treatment in older age, we use Ross operation, Ozaki procedure. We are used to we have to place the mechanical valve. I would say that approximately 30% of our surgery is done in the neonatal age. 60% of surgery is done during the first year of life. And also I would say that up to 15% of operations are re-operations in our practice. On the beginning of second decade, the second millennium, I think we had a major breakthrough in the education of our perfusionists. We spent quite a long time in Great Ormond Street Hospital in London, and we could see great improvement in conduction of cardiopulmonary bypass, especially in the needs. Now we are using conventional and modified ultrafiltration routinely. As for the cardioplegia, we are using blood cardioplegia. For the longer procedures, we tend to use Del-Nido cardioplegia. We tend also to use normothermic cardiopulmonary bypass as much as we can. Selected patients are nevertheless still operating in deep hypothermic cardiac arrest, predominantly normal procedure, surgery for the aortic arch, reconstructions. Also, we lab to operate total anomalous pulmonary venous connection in circulatory arrest, but we are still very fond of using isolated myocardial and cerebral perfusion, especially in NORBIT procedure. We standardly use cell saver in redo operations, and now in Institute for Mother and Child in Tishova, there are 6 trained perfusionists that are just involved in pediatric cardiac surgery. As for the international cooperation, I mentioned that apart from 30 years long institutional cooperation with Great Ormond Street Hospital in London, where most of the Serbian surgeons were trained in the last 30 years, these 3 surgeons have greatly enriched our knowledge in surgical practices. It's Professor Kalangos, Dr. Bruno Muzzi, and of course Martin Costone. Professor Kalangos paid us a regular visit from the period of 2005 to 2013. He did numerous operations, predominantly on patients with Epstein disease. He has done more than, I think, 5 to 6 corner procedures in our hospital just. He was also involved in treatment and operations of very severe Gooch patients. basically he teaches us to do the Ross procedure. Afterwards, Professor Illich placed Ross procedure in our routine practice. So basically, I would say that we learned to do a Ross procedure in fashion that he taught us. He was also very involved in education of predominantly adult cardiac surgeons. Some of them trained in Geneva. Also, he was very helpful because he was the person that made a connection with Monaco, and some cardiologists were trained in nuclear magnetic resonance in Monaco because of his help. And he was also very grateful because he made numerous donations. For example, he donated us complete ECMO equipment, numerous others medical equipment. Dr. Bruno Murz is our friend from Toscana, from Gabriella Monasterio. He paid us a visit in 2013 and up to 2018. He was involved in operations of complex mitral anomalies in infants, also infants with severe left ventricular outflow tract obstruction and reoperations, predominantly the ones with the Schramm complex. He was also involved with other complex surgical treatments. And also it's interesting that 3 of our surgeons from Serbia were trained with him in humanitarian missions in Africa and Eritrea with his foundation, Uno Coro, Uno Mondo. Martin Costoli paid us regular visits since it's been now 11 years. Initially, he was involved in surgical treatment for the patients with CCTGA. He was doing 5 to 6 double switches here in Serbia. In the last years, he is mainly involved in the treatment of patients with pulmonary atresia and MAPCAS. He's doing most of our cases that are scheduled for unifocalization of MAPCAS. He's also involved in the treatment of patients with transposition of the great arteries and left ventricular outflow tract obstruction. He performed a couple of Nikaido and draft procedures in our hospital. And he also taught us to do the Ozaki procedure in selected patients. Afterwards, Professor Illich also placed this procedure in routine practice in our hospital. What is the current situation for the referral of the patients for abroad treatment? Yearly, up to 10 patients from Serbia are referred for medical treatment abroad. Most of them are referred to Martin Kostelnik in London. Some of them are referred to Martin Kostelnik in Leipzig because of our very long and fruitful cooperation with Ingo Denner, who is our friend and cardiologist who's been coming to Tiršova Clinic for more than 20 years now. And some of the patients, of course, still referred to Professor Kalangos. What is the current situation with ECMO? ECMO equipment was, as I mentioned, donated to us by Professor Kalangos more than a decade ago. He gave us 2 Levitronic pumps with a heater-cooler system. We have done 7, I think 8 ECMO procedures afterwards. Unfortunately, since 2020, the production of consumables for Levitronics was stopped. So currently, we have no ECMO, rather pediatric circulatory support in Serbia. Nevertheless, Serbian Ministry of Health plan to open National ECMO Center in Tiršova Clinic next year, and the equipment is bought and ready to use. What is the situation with transplantation? National Heart Transplantation Program is still in the early phase of development. In Serbia, up to 10 heart transplantations is done annually in adults. Serbia is unfortunately still not a member of Eurotransplant program, so there is no treatment strategies for children with end-stage heart failure in our country. What's the situation with the Gucci program? In Tiršova Clinic, basically we are operating on patients up to 25 to 30 years after tetralogy of follow repair if they need replacement of a biological or other valve in the pulmonary position. starting from 2019 in Institute for Cardiovascular Diseases, there is a center, good center. They are making a collaboration with Professor Alessandro Giamberti from San Donato. He's been coming to Serbia regularly since 2014, and he has performed some more than 100 surgeries in selected GUJ patients. We still don't have regular conferences with discussions over select GUJ patients between adult cardiologists and adult cardiac surgeons and pediatric cardiac surgeons. We still don't have central registry of Serbia GUJ patients. There is no standardized transfer from pediatric to adult cardiologist for the patients with treated congenital heart disease, and unfortunately, there is no domestic surgeons that are trained or interested in pathology. And for the end, these are the phases that are present in the future of pediatric cardiac surgery. Me and Dr. Dejan Bisnic are working in Tiršova clinic, Ivan Dizdarević is working in Institute for Mother and Child. And I hope that we will have a slightly easier path in the future development of pediatric cardiac surgery than our teachers. Thank you for your attention.
Hello, can you hear me? Hello?
Hello, can you hear me?
Can you hear me?
Yes, I can hear you. Yeah.
Yes, yes. Thank you very much, Dr. Milovanovic, for that nice presentation about the situation of pediatric cardiac surgery. I was trained myself with Martin Kostolny in Great Hall Street, and Martin is a very good friend of mine, actually. Basically, so I'm sure the standard of surgery in Serbia will be very high. Just a few questions, Dr. Milovanovic. The first is, how is the funding of pediatric cardiac surgery in Serbia? Is it government funded? Is it insurance led, or how does the funding happen?
I'm sorry, but I can barely hear you. Something is happening with your microphone. I can't.
Just a minute. Is it better now?
It's a bit better, yeah, yeah.
Yes. Hello? Is it clearer now? Is it clear
I can hear you
now?
now, yeah.
Yeah,
Yeah, it's much better, yeah.
Okay. Thank you very much for your presentation. I trained with Martin Kostolny in 2012, so he's a very good friend of mine. And I'm glad to see that he's involved in training of children in Serbia also. And you seem to be doing practically everything, except maybe for transplants and some sort of complex work related to GUJ, I guess. Right?
Well, I would imagine that you asked me about the transplantations in GUJ patients.
Yes.
Well, the problem is as I mentioned in this slide regarding transplantations, the development of heart transplantation program in adults is around 10% annually are having a transplant in Serbia, and that is, as you can imagine, very, very low number. For example, in a neighboring Croatia, they have more than 50 transplants for a year, and they are more than double smaller country than Serbia. So basically, we don't have a treatment for pediatric cardiac patients that are at the end stage of heart failure. Unfortunately, we have a problem with ECMO also, because our equipment is not produced anymore. So we're waiting to buy new equipment, and then we can start again with the ECMO program. We're still far away from, for example, establishing a Berlin Heart program or whatsoever. I hope that in the next year or two, we're going to start again with the ECMO program, not just in the pediatric cardiac patients, but also the Ministry of Health has a plan to establish a national ECMO center where all neonates, not just with congenital heart disease, are going to be referred.
Thank you. Just one more question. How does the funding of cardiac surgery happen? The funding, is it a government? The funds, the financing?
The financing, you can imagine the situation. You can imagine the situation of financing, you know, in Serbia. I didn't mention that in the previous slides, but you know, we had a complete breakdown of the system during the 90s, and afterwards there was a, I would say, the beginning of organized program in 2 centers. But there is always problem with financing, not just the equipment, but also we have now a permanent problem with the shortage of nurses because of their salary, which is, you know, you can imagine how bad it is.
And are you meeting the need of the country, or do you have a long waiting list?
Our waiting list is pretty long. I would say we are doing around 400 cases in these 2 centers. And in Tiršova clinic, there is a waiting list of approximately 100 patients.
100 patients, okay.
100 patients, yeah. So I would say that there is a potential of doing 450 patients annually in Serbia totally.
Yeah. Okay. Thank you very much.
Okay, thank you.
I think we'll move on to the next presentation. Hello. Good afternoon, Professor.
Good morning again, Dr. Ragini. Happy to see you again.
Yes. Oh, hello, Professor.
Yes, a very beautiful presentation, Dr. Milovanovic. Really, and I'm deeply touched because in each occasion, you know, especially the Serbian physicians, doctors, they mention my name, and really at each occasion, you know, you deeply touch me. Now, I will present you the good surgery, as you mentioned also in your presentation, Dr. Milovanovic. Now, good surgery started becoming a necessity, especially in developing countries which have already a very sustainable program of pediatric cardiology and pediatric cardiac surgery. And for some educational issues, I wanted to present especially the whole good surgery. Could I have my, yes. Yes. Now, GUCH, as you know, means growing up congenital heart diseases. Is, you know, all the congenital cardiac malformations at adult age. In Europe, we are 742 million inhabitants, and as you see here, 2.8 million adults are suffering with severe congenital heart disease. As you see here, this publication is from Marelli and published in a very good journal in Circulation. In this GUCH population is growing up by 5% per year. And in 2005, as you see here, the number of adults has for the first time surpassed the number of children in the region of Quebec in Canada. It means, now in the near future, we will have more adult population suffering from congenital heart diseases than pediatric population. And for that reason, it's becoming a very important problem, and especially, all these countries which have already this pediatric program have to start thinking how to implement the good surgery and the treatment of this, the diagnosis and treatment of this adult congenital heart disease patient. Now, based on DIN field, there is a need for one specialized center for every 5 to 10 million inhabitants. It means that in Europe we need between 70 and 140 centers. And based on the estimates done by Marelli, we need 65 centers. It means, one specialized center for every 2 million inhabitants. When we are talking about GUCH, we have to tell that, especially in GUCH patients, the number of sternotomies, resternotomies, is constantly increasing. As you see here, from 74 to 2012, especially in my center, the number of resternotomies started increasing because of also of this GUCH patients coming sometimes, many times to surgery. Regarding, the Aristotle basic complexity score, these cases are also sometimes very complex, and for this reason, as you see here, the complexity score also is constantly increasing. It means, cardiac surgery is becoming more and more complex. The hospital mortality regarding this GUCH patients is fluctuating between 1.5 and 3.6%, and you have here the statistics of the big centers worldwide: Erasmus, Royal Brompton, Marie Lannelongue in Paris, Atlanta, Mayo Clinic, as you see here. But the mortality rate, despite the complexity of these cases, I can tell is low. Now there is 4 categories of GUCH patients cases. The first one is the primary correction at adult age of previously untreated defects. It means that we will discover the defects later on at adult age. The second category is the surgical treatment of residual defects after previous correction. The third one is the surgical treatment of new pathologies associated with congenital heart diseases. And the last one is the treatment of acquired heart diseases in GUCH patients. Let me start with the untreated defects. In this first category of untreated defects, the most frequent cardiac malformation is the atrial septal defect, followed by the partial abnormal pulmonary venous return. Then we have the Epstein's malformation. We have the partial AV septal defect, VSD, coarctation, tetralogy of Fallot. Then we have arrhythmias, heart blocks. And then we have, now we started also, especially with CT scan angiography, we started also discovering a lot of abnormal coronary arteries, either, from the aortic origin or, from the pulmonary artery. And this one, this first category represents 40% of the GUCH patients. Regarding the AST closure in adult population, again, as you see, the tendency is to close them because usually they are, small holes, small defects, and the tendency is to close them interventionally by Amplatzer. And the number of surgery, as you see here, is declining. Regarding the Epstein's anomaly, now, up to now I operated around 160 patients, and I'm trying to publish them. And I checked again, in this large series, what is the percentage of adult Epstein's anomaly. As you see, between 93 and 2021, 19% of these patients were more than 18 years old. As you see here, I will not enter into the details of the surgical technique, but here, there is the Carpentier's technique. There is also the new cone technique described by Da Silva. Usually, I utilize the modified Carpentier's I develop myself. As you see here, we detach the septal leaflet, the displaced septal leaflet, posterior leaflet, and 2/3 of the non-displaced anterior leaflet from their native annulus. And then we do the plication of the orifice to bring the dilated orifice to the physiological dimensions according to the surface of the present tricuspid tissue. And then, as you see here, from the anatomic level, you bring up the valve, all the valvular tissue, by creating a new tricuspid valve to the physiological level. And now regarding, as you see here, the atrialized chamber, usually I stop plicating the atrialized chamber. First, because sometimes it's unnecessary, because by plicating the atrialized chamber, you decrease the new right ventricular cavity, and on the other hand, also, you can create an injury of the posterior descending artery, especially if this one arises from the right coronary artery. And another pathology after Epstein's malformation is untreated defect is the correction of tetralogy of Fallot or pulmonary atresia in adult population. Here I will show you the movie. Look, this case arrived with absent pulmonary valve and pulmonary annular stenosis. The patient was 20 years old. I operated in Geneva, and this case was part. Now I am cutting the narrow pulmonary annulus. As you see, there is no pulmonary valve. There is a huge VSD, Fallot-type VSD. I am closing the VSD with a bovine pericardium. With a running suture, as you see here. After the closure of the VSD, I am preparing the pulmonary trunk for the implantation, as you see, of an aortic homograft. Usually I prefer the pulmonary homographs in the pulmonary position, but unfortunately sometimes it's very difficult to get them. And for this reason, in some selected cases, I put the aortic homograph. I prefer the use of aortic homograph in the pulmonary position, especially in cases with pulmonary hypertension, because in these cases the pulmonary valve is not enough strong to persist against the high pulmonary pressures. Now, you know, if you correct the tetralogy of Fallot at adult age, you see it was published by Horer. The mortality is high, is 15%, and the late mortality at 12 years, post-operative 12 years, is 11.5%. And as predictor factors of post-operative mortality, Dr. Horer published that the high preoperative hemoglobin level is one of the predictor factors, as well as the right ventricular, the need to enlarge the right ventricular outflow tract with patch. Again, another untreated defects, it was a late discovery of a coarctation in a lady of 18 years old. As you see here, there was an aortic ischemic coarctation, and unfortunately, in this late arrivals, you have also, in some of them, this post-stenotic aneurysm of the initial portion of the thoracic aorta. Again, as I mentioned at the beginning of my speech, now we started also discovering a lot of abnormal aortic origin of left or right coronary arteries, because we increased also the number of CT scan coronary angiographies or thoracic angiographies, and really also this one is a big problem, and probably, you know, at the next global forum in 2025 I will present perhaps, you know, this coronary artery anomalies, which is a hot topic now. Here you see a recent case I operated in Greece. The abnormal origin of the left coronary artery from the right sinus of Valsalva, and usually there is an interarterial course, and sometimes this interarterial course is also into the mural portion of the ascending aorta, and this one is intramural interarterial course. And especially these cases, you know, are very difficult because the intramural course is a risk factor, high risk factor. What we do in these cases, we remove, we resect especially this portion of the aortic wall. We enlarge, you know, the ostium up to the normal course by decreasing especially, you know, the compression of the pulmonary route to this abnormal artery. It means, you know, as you see here, all this aortic wall should be resected until, you know, the potential non-compression point, yes, which is here. Then again, you know, there is also sometimes, usually, you know, we treat the Al-Kappa or R-Kappa in the neonatal stage or late, especially the R-Kappa, the abnormal origin of the right coronary artery from the pulmonary artery. But sometimes, you know, there is also late arrivals, and which is not very frequent with Al-Kappa, the abnormal origin of the left coronary artery from the pulmonary artery. 2 years ago, I operated a case in Istanbul. It was, you know, a 19 years old pregnant woman with pulmonary hypertension. She arrived, you know, with pulmonary hypertension, and then, you know, I started asking for some investigations, and I was surprised because we discovered, you know, this abnormal left coronary origin. the pregnancy was good. She delivered the baby, and then I operated on, and we published, this exceptional case in chest in 2021. And as you see here, the abnormal origin of the left coronary artery arising from the pulmonary root. Yes, as you see here. Yes, the left. And it was, the entire left coronary artery. Sometimes, you have only the LAD arising from the pulmonary root. And when you have, this kind of Al-Kappa cases, the right coronary artery, which is taking in charge, retrogradely the perfusion of the right coronary artery becomes dilated. As you see here, the origin, the initial portion of the right coronary artery, which is dilated. Now, regarding the conclusion for the first category of untreated defects, first, we have frequently this shunts on atrial level. As Epstein's malformation, we have, this valve pathologies. We have the abnormal coronary anomalies, sometimes the left heart obstructions. Usually, in this first category, I cannot say that surgery is very complex. And the outcomes in this cases of first category will be determined by indication and comorbidity. Now, the second category is the surgical treatment of residual defects at adult age after previous correction in childhood. And here, usually, you have the pulmonary valve surgery. And the pulmonary valve surgery in Guch represents more than 50% of operations. And then at the second position, you have the left AV valve surgery following atrioventricular septal defect repair. And then you have the surgery for residual left ventricular outflow tract obstruction. You have the residual VST repair, and especially, in atrial switch, staining or master, you have, the baffle leak closure and so on. Now, regarding, the pulmonary valve surgery, because we started also using a lot of xenografts, especially, Contegras, and the problem of this Contegras, especially, used in the pediatric in small children with the implantation of small sizes, they are at the origin of some problems. And the most important problem we face is, this distal stenosis at the distal anastomotic site between the contegra and the pulmonary arteries, as you see here. And unfortunately, gradually, these contegras, they are becoming, very calcified. And I had also a biological valve which was, calcified 5 years after its implantation, because there was this child was operated in another center, and there was no access to contegra, and the surgeon preferred to use a biological valve as pulmonary valve for the reconstruction of the right ventricular outflow tract obstruction. And after 5 years, as you see, the biological valve was completely calcified, as you see here. This one we know very well is due to the fact that in children the calcium metabolism is very active, is very high, and for autism, I believe we have to avoid the use of biological valves in children, especially in young children. As I mentioned, over the past 40 years, we started using more and more this valvular conduit, especially, more xenografts than homographs, because there is few homograph banks in the world. And as you see here, we had 1,439 conduits, and most frequently implanted in cases of pulmonary atresia with VST, following with tetralogy of fallow cases, 24 and 22%, and at the third place we had, the corrected transposition with pulmonary stenosis. And again, you know, this one is also important. In neurosurgery, you use also by obligation a homograph, especially to replace the explanted pulmonary valve, which is going, you know, to the aortic position. And the percentage of use of conduits, valvular conduits, in Ross surgery is 3%. The Ross surgery is 3% concerning the use of valvular conduits. Regarding the other choices, as I told you, we have the homographs, then we have the bovine Hancock valvular conduit. Again, as you know, the surgeon did, we have the biological prostheses, but I cannot recommend them. Especially, you know, there is Contegra, is the most frequently used valvular conduit now. And there is, you know, the shell high, and you can also put, you know, if there is nothing, and if you are obliged, you know, to do the surgery and to put a valve at the pulmonary position, you can also use a mechanical prosthesis, which is not recommended. Regarding, you know, the use of the xenograph, as you see, the Hancock porcine valve, it was published by Bailey from Marie-Lalonde, Paris. As you see, at 12 postoperative years, unfortunately, structurally, all the porcine valve Dacron conduits will be degraded at the valvular level. You know, for small sizes, regarding, you know, the homograph versus xenograph, regarding the big sizes above 15 millimeter, regarding, you know, the homograph and the xenograph, the statistical difference p-value is 0.02. There is, you know, more structural dysfunctions, deterioration with the xenograph than with the homograph. Now, the other option, especially when you have structurally deteriorated valvular conduits, big valvular conduits, the choice is the percutaneous pulmonary valve implantation, the Melody valve. And now there is also other percutaneous valves developed by the industry, especially, you know, in cases where there is no valvular conduit. First, you know, they put a stent, and then, you know, a few days later they go and they implant a pulmonary valve inside this pre-implanted stent. Here, as you see, the number also of this percutaneous pulmonary valve implantation is constantly increasing. And now, probably in the near future, surgery also, the number of surgical cases will decrease. I cannot change my... Yes, there's a problem. Yes, okay, thank you. Now, regarding the conclusions for the second category of residual defects, again, you know, they are this one complex congenital heart defects. Pulmonary valve, as I mentioned, is often involved, more than 50% of good surgeries. Again, outcomes will be determined by the experience of the surgical team, because they are repeat sternotomies, don't forget. And this, again, you know, outcomes will also be determined by indication and comorbidity factors as in the first category. Yes. Now, yes, yes, now the third category is the surgical treatment of new pathologies associated with congenital heart diseases treated in childhood. And what are these new pathologies is recoarctation, especially after initial coarctation surgery, is the aortic insufficiency and aortic root dilatation, especially after the transposition of great arteries, and other pathologies. I will mention this one. We started also, the interventional cardiology started using more devices, and these devices, they have also potential complications. I will also mention this one. And there is the failing Fontan cases, and then we have arrhythmias and heart blocks. Now, new pathologies, these cases I would like to show you. I operated many years ago, 51 years old male, who was initially operated on by the interposition of a Dacron graft of 16 millimeter in diameter when he was 17 years old. And then over this years, he developed a gradient at the site of the isthmic aorta, where there was, the graft, a gradient estimated at 35 millimeter of mercury, as you see here, with a post-stenotic aneurysm of the, as you see here, of the remaining part of the thoracic aorta. And I did a thoracotomy, left thoracotomy, with femoral bypass, and I resected the previous Dacron graft. I interposed, as well as the dilated aneurysmatic descending aorta. And as you see here, I interposed a big graft, Dacron graft of 24 millimeter in diameter. Now, the other one is the aortic aneurysm after initial surgery. Usually, we have the aortic aneurysm after Ross procedure, after tetralogy of Fallow or double outlet right ventricle, or after arterial switch, as I mentioned. Here you see it was published in the Annals of Thoracic Surgery, a case of correction of tetralogy of Fallow 18 years after, with an aortic aneurysm. Regarding, the Ross surgery, because we started doing more and more this kind of surgeries, especially I strongly believe that if you would like to deal with problems of aortic valves in children, is the only valid option, Ross surgery, as it was presented also yesterday by Professor Fotiadis, very nice presentation. But the problem of the pulmonary root at the aortic position is dilatation. In subcoronary implantation technique, there is no dilatation because you preserve the native aortic root. You implant only the pulmonary valve at the aortic position. And then, in order to avoid, this problem, we started also reinforcing the weak pulmonary root, either with a Dacron graft, as you see here, around the pulmonary root, or with the inclusion technique with the native aortic root wall, as it was presented by Fotiadis yesterday. And in this reinforcement cases, the Ross with reinforcement, there is, as you see here in this curve, there is the same result as in the subcoronary technique, not a lot of cases with late aortic aneurysm or dilatation. But without enforcement, as you see here, at 10, 12 years, the freedom from autograft reoperation is 85%. It means in 15% of cases, the surgeon has to deal with new aortic root dilatation. Again, the other problem is with neo-aortic root dilatation is after the arterial switch operation, and as you see here, at 20 years, around in 10% of cases, there is important aortic root dilatation, and these cases have have to be reoperated on. When you have this kind of neo-aortic root dilatation, we have two very well described techniques. The first one described by David, as you see here. I will not enter into the details. And the second one described by Sir Magdi Yacoub, as you see here on this illustration. Regarding another chapter of this third category of neopathologies, there is, the atrial switch operations, Senning and Master, and you see the survival is true that is better in arterial switch operation compared to the Senning to the atrial switch operation, Senning or Master. But on the other hand, the freedom from reoperation is best, is better, in Senning operation, and then following by arterial switch, and then Master surgery. Because in Master surgery, you don't use the native tissue, cardiac tissue, atrial tissue, and you use more, the Dacron or a synthetic material to do the buffle, and there is a lot of problems related to this buffle. Especially the problem, as I mentioned, is with the problem, and usually, when you see the survival after reoperation, when you reoperate for buffle complication, you see that around 15% of cases at 5 years will need a new surgery. It means by reoperated on these cases, you don't definitely the complication, the needs for reoperation, resurgeries, and if you reoperate the Senning and Master cases for systemic ventricular failure, and usually why we operate, because there is an insufficiency, significant regurgitation of the systemic valve, and at the systemic position you have the tricuspid valve, which is a weak valve. And this repaired valve also can fail again, and as you see, in 35% of cases at 5 years, there is also some need for something else, because unfortunately 35% of cases will not survive. Globally, the survival after 40 years in classic Fontan operation is 78% at 18 years. Here, after 18 years, they started having a few patients, and for reason we cannot be conclusive. If you have this kind of failing Fontan, what you have to do, you have two options: the conversion of the Fontan versus transplantation, and especially regarding the comparison of these two surgical options, Van Mel published in Heart in 2016 that in failing Fontans, conversion is better than transplantation, because as you see, the event-free survival is better in conversion than in transplanted cases. We know in case of transplantation, the survival at 10 years is 50%, and during the first 6 years after transplantation, the survival is better in non-congenital heart disease group. It means if you transplanted a Gooch patient, you can expect less survival at 10 years than the non-congenital transplanted group. If you have a failure of the systemic ventricle, of the single ventricle also, you have different options in the Fontan operation. You can put a right ventricular assist device. You can put a biventricular assist device between the single ventricle, the aorta, and between the Fontan conduit and the pulmonary artery. Or, if your pulmonary tension is low, and if really is a failure of the single ventricle, then you can put only a left ventricular assist device as a bridge to a transplantation. I will finish this category with this complications related to use of devices by our interventional cardiologist colleagues. This one was published by Vogue in the International Journal of Cardiology. 11 device explants between 1 and 8 years after intervention. As you see here, there was one of them, five of these cases were operated on because there was thromboembolic events due to the thrombi develop on the surface of this foreign body. There was, a residual shunt due to the dislocation of the device in 3 cases. There was a growing mass in 1 case. In 2 cases, the thrombi were responsible for coronary embolism, and one of them was resuscitated due to ventricular fibrillation. Here to conclude with the third pathology, again, as you saw, they are complex cases with end-stage congestive heart failure, especially, in failing fontans and in Senning and master cases in atrial switch operations. Again, the outcomes will be determined by the experience of the surgical team, because there are also repeat sternotomies, and again by the indication and comorbidity. And this one especially is a future challenge with the arrival of the new technologies in terms of left ventricular assist devices and artificial hearts. To finish with the third category, with the treatment of acquired heart diseases in good patients, I took, this one I will present a little bit my series. We have in this cases operated for the congenital malformation. They can also develop, as everybody, aortic dissections, coronary artery disease, endocarditis, and late arrhythmias or heart blocks. This one, as you see, between 2001 and 2011, I operated 35 good patients, and mainly, for coronary stenosis. And with CABG, I was obliged, to do also some concomitant surgeries, AST closure in 32, VST closure in 2 patients, and PDA closure in 1. And this category, this third category, represent 4% of good surgeries. Again, as we started also implanting a lot of now melody valves, percutaneous pulmonary valves, there is also infective endocarditis, and this risk, as you see here, is increasing and becoming, sometimes 25% at 40 months. This one, is a publication article published in JACC. And then you have to implant all this foreign body, as you see, and put in these cases of infective endocarditis pulmonary homograft. Again, regarding the conclusion of the fourth category, all acquired heart diseases may occur in congenital heart defects. Again, outcomes will be determined by experience of interdisciplinary team, because in these cases, the adult cardiologists, non-invasive or invasive cardiologists, intensivists should be also included. And again, the outcomes will be determined by indication and comorbidity. Here also we have the future challenges, especially, regarding the arrival of the new technologies concerning the percutaneous pulmonary valve implantations. Now, in conclusion, I can say the good surgery is a valve surgery. I show to you is more than 50% of cases. The need for pulmonary homograph, or if you don't find it, you can put an aortic homograph in the pulmonary position. Good surgery is a redo surgery. And the planning of this redo surgery starts before initial correction. And for this, you have to create in your institution and interdisciplinary team, very important. The outcome is determined by indication for surgery and as well as by the experience of the surgical team. And for this, the best option is to send somebody to be trained abroad in a big Guj center, in one of the big Guj centers around the world. The complete diagnostic workup is essential because this usually, these cases, they don't have only, a cardiac problem, but they have also some kidney problems, some neurological problems, and for autism, especially in this category, there is also ladies, and sometimes, they have gynecological problems, or, they have the expectation to procreate, and all these things should be taken into account. Outcomes depends on comorbidities because there is a lot of pre-op morbidity factors, and the end stage congenital heart disease is the future challenge, especially with technological advances in assist devices and artificial heart. Thank you very much.
Thank you very much, Professor. As usual, I always learn a lot from all your lectures and your very comprehensive coverage of this topic. And what I liked a lot, Professor, was rather than clubbing each into just one category, you actually divided into the four very good categories, and I think they should be universally accepted, Professor. Because what we see in my practice in India is the category 1, what we call as unoperated congenital heart diseases, which present at a later age, basically. And what we are seeing in the West is perhaps category 2 and 3, more of category 2 and 3. And like you said, the results, the outcome will depend on multiple factors. So, Professor, one question to you is, should we use this as a universal sort of criteria for classifying which patients, one, and should there be a risk stratification based on this classification rather than clubbing them into one?
Regarding, I didn't understand, you are asking the complexity of cases? I didn't.
No, what I'm saying is like operating on, when we were in the West, you operate tetralogy of Fallot before 9 months of age. And I operate tetralogy of Fallot anywhere between from 6 months of age to 35 years of age, or even 42 years of age. Obviously, they do not behave the same.
Yes, it's not the same, as it was presented, in this publication of horror. Unfortunately, the late arrivals of tetralogy of Fallot is a huge risk factor. Especially, this one is also presented by Katsoulis from Royal Brampton Hospital. When you operate, these cases late in their lives, unfortunately, you have also more sudden death because, they are exposed, to unsaturated life, and this one is a limited factor of life expectancy. And the more you have, this exposure to low saturation rates, the more you have increased sudden death rates. And for that reason, the best is to try to operate what I do, the tetralogy Fallot of cases, I operate them at 6 months post after birth, the 6th month. This one, is the best timing, because there was also a publication, I don't remember, in which they saw which is, the best timing period to to correct the tetralogy of Fallot or the cyanotic defects. And the 6 months they have enough weight and they are not exposed a lot to the low saturation levels, and for artisan I believe the best timing is the postnatal 6 months.
Yeah, thank you, Prof. Prof, just one more question. Should we have a separate risk stratification or a complexity score for each population?
Yes.
Especially for category 1.
Yes, when I check my series, because I have also a very large series of Gucci population, the untreated defects, if there is no pulmonary hypertension, you have the low mortality rate. But if you have residual VSTs and significant holes and pulmonary hypertension, then the mortality rate is increasing in this category. But especially with ASTs and with all these percutaneous interventions, the mortality rate is really very low, because as I show you in the first category, you have the simple defects, the ASTs, or small VSTs, what we are seeing. But sometimes for example, now I had somebody from Albania, 25 years old, and it was a sad story. It was discovered when he was 1 year old, and the family was afraid of the fact to bring their child to surgery. And now he has Eisenmenger syndrome, and there is nothing to do, only a POTS anastomosis and nothing else. And he is under this heavy medication with Bosantan, sildenafil, and so on. And the other option is the pulmonary, is the heart-lung transplantation, which is impossible to do in Albania. The first category, can get complicated cases if really this untreated defects had an evolution toward Eisenmenger syndrome due to progressive pulmonary hypertension. Otherwise, the mortality rate is low. As you know, in the routine cases, we do in adult cardiac surgery. But the second and the third category, the third category, the second category, I show you, this coarctation, the aneurysm. This one is a complex surgery. The other category with the pulmonary valve, also I do, if there is no residual defect, I do, pulmonary homograph implantation. And this one, the mortality rate is really very, very low, not exceeding 1% if there is no comorbidity factors.
Okay, I don't know if you can see my presentation. Good morning from me. I'm sure that I changed the program, but I had a flight in Bucharest and I don't have any luggage with me, and I have to hurry on to go back to the airport. So first of all, I would like to thank Professor Kalagos for his very prestigious invitation on this 14th Global Forum of Humanitarian Medicine in both cardiology and cardiac surgery, and I'm really envious for the Euro-Asian Symposium of Pediatric Cardiology and Cardiac Surgery. It's a pleasure for me to represent our country and regarding the interventional cardiology in Gucci. I have to admit that there is no structured program for interventional cardiology to treat patients, adult patients with congenital heart disease. In the last year, we tried to develop a program, such a program in Hippocration in Athens, with Dr. Drakopoulou, that she was a congenital. So we tried to develop a program, and I would like to share with you some cases and some thoughts regarding this problem. Regarding the interventional cardiology in generally, and also in our country, we know that we can treat now mitral valve very well. We know that stenosis is still a problem. However, we can treat it properly with balloon valvuloplasty. There is no much there with MAC. regarding the interventional cardiology, but still we have some progress. The insufficiency and the regurgitation, we know that we have the TEER procedures that we treat patients. A major step down was step up. I'm sorry, was the treatment of the percutaneous treatment of aortic valves, and the last 20 years we saw the evolution of TAVI in these patients. We have some progress now regarding the tricuspid valve, pulmonary valves, prosthetic valves, and these are all implicated in the interventional cardiology of goods, and we're trying to have a special program regarding this. And also the Hellenic Society of Cardiology tries to advance this field, which hopefully will be recognized as a sub-specialty in Greece, and hopefully we're going to have a structured program for the treatment of these patients. So I would like to share you with our last procedure, which was done, a transluminal implantation of pulmonary valve melody. After a ROS procedure, this is the main treatment that we are dealing with in Hippocratium. This is a patient, 32 years old, born in 1991. And we did it last year. This with subaortic stenosis was the first diagnosis. At the age of 4 years old, he had a surgical resection in Hagia Sophia Hospital in Athens. In 97, 6 years old, redo surgical resection in the same hospital. And at the age of 14 years old, he had a Ross Cono procedure in the Royal Broadmoor Hospital in the United Kingdom due to severe and complex left ventricular outflow tract obstruction. He had a peak gradient of 100 millimeters of mercury. The pulmonary diameter was then 17 millimeters, and the aortic rim was 19 millimeters. There was a tunnel, and in addition, a discrete stenosis with mild to moderate aortic regurgitation with a general good biventricular function and no co-attraction of the aorta. During the procedure, the pulmonary autograft was placed in the aortic position, and a size of 21 millimeters aortic homograft was implanted at the pulmonary section. So this was generally the medical history of the patient. And during the last years, there has been a gradual increase in the transpulmonary gradient, where I remind you, he had a 21 aortic homograft, and the patient complained about progression of dyspnea on exertion. So the patient was now in the New York Heart Association functional class of 2. This is the echo of this patient, the transthoracic pre. You can appreciate the LV. You can see the left atrium, good LV function. However, you can see here the gradient in the area of pulmonary artery with more than almost 5 meters per second velocity. This is the cardiac CT for planning of intervention in the pulmonary valve. You can see here, you can appreciate the ascending aorta, and here's the aortic graft, which was implanted in the right ventricular outflow tract here. And we did the CT to evaluate the exact diameters, as you can appreciate here. The distance from the coronary arteries, which is very important. You can see here the distance from the homograft to the ostium of the coronary arteries, which is really important for the planning of the surgery of the procedure. As you know, if it's more than 5 millimeters, this distance is a low risk for obstruction. If it's less than 2, then there is a problem regarding the procedure. And we can appreciate the aortic homograft, the coronary buttons, the failed pulmonary homograft, and the distance from coronaries and the internal diameter. This is the angiogram for the pulmonary artery. You can appreciate here. There's nothing special about that. The balloon sizing, you can appreciate here again. You can see the calcium of the homograft and the sizing of the balloon. Here again. And here's the procedure with the pre-standing of the pulmonary homograft. And in a different projection here, you can see the balloon sizing, the pre-standing, and after the standing of the area, in order to avoid any rupture, we have the melody implantation in this in the standing segment, as you may appreciate here. And post-angio, we have this angiogram. You can see there's no regurgitation. It's satisfied the implantation and expansion of the melody valve in the pulmonary artery. This is the post-TD, transthoracic, and you can see that the velocity is almost 2.5 meters per second. I just want to remind you that the transcatheter pulmonary valve replacement started in 2000 by Philip Bonhoeffer. He was the first to publish in the Lancet the first percutaneous replacement of pulmonary valve in a right ventricle to pulmonary artery prosthetic conduit, which obviously had a valve dysfunction. And generally, from the right ventricular outflow tract dysfunction, the target population is mainly the patients with ROS and, of course, Fallot, and these are the patients that we indicate. We know that surgical correction for the treatment of the trials of Fallot and the RV outflow tract anomalies is of course a solution, a permanent solution, especially in patients with pulmonary stenosis, and it's approximately to 85% of these patients. In all other RV outflow tract anomalies, you can see that which account for the 15% of the dysfunctional right flow outflow tract patients, who can also have percutaneous treatment. However, we have to emphasize that the pulmonary valve replacement and the elimination of regurgitation or stenosis, as it was published in 2010 in Circulation, it shows that the randomized trials for replacement with or without remodeling, they don't change RV ejection fraction, and there is unchanged exercise parameters in these patients. However, there's improvement in several other factors which we have to take into account. So the current indications for pulmonary valve replacement, as you may see here, is mainly based on symptoms of the patient. So if we don't have any symptom, then we can follow the patient regarding the exercise capacity, the RV function, and the tricuspid regurgitation, the right ventricular systolic pressure if it's more than 80 millimeters of mercury, if there is right to left shunt through ASD or VASD. If yes, then we're going to go for intervention. If there's no, we can have a close follow-up of the patient. However, if we have the symptoms and we have management of regarding the right ventricular outflow tract obstruction, then we have to proceed for the intervention, and this is class 1 based with a level of evidence C that's recommended in patients with severe PR with symptoms and at least moderate obstruction of the RV outflow tract. In patients with no native outflow tract, catheter intervention should be preferred in anatomically feasible patients. And this is class 1C again. For the class 2A-C, you can see all the other that I have already told you, the other parameters that we should take into account. The melody valve is a good valve that you can size it from 14 to at least 20 millimeters. There's an ability to accommodate it through a 22 French delivery catheter with a conduit originally greater than 16 millimeters. You can see the outflow gradients from the baseline, how are they decreased, and we can have data from 5 years follow-up that there is no increase of the outflow RV outflow tract gradient, so we can have a sustainable result throughout 5 years, and there's freedom from catheter-based reintervention of the melody in more than 80% out to 5 years, which is considerably acceptable in this population. The main problem, of course, is the infective endocarditis after melody valve implantation in the pulmonary position, and this is a systematic review from 851 patients, and they had a cumulative instance of internal of infective endocarditis from 3.2 up to 25% in these patients, with a death rate which approximates 9%. The long-term, however, outcomes after melody, you can see it in the US, the investigator device exception trial. You can see that freedom from death is more than, is almost, is 92% in ages less than 21 years old, and 88% in ages more than 21 years old at 10 years. And if we proceed in more than 21 years, the freedom from dysfunction of the valve is 64%, and 46% in younger patients less than 21 years at 10 years. So the ID study showed that patients at 10 years after melody implantation, which is the longest follow-up in the study, it's acceptable that 9 out of 10 patients are free from death. The predictive factors after for any reintervention after melody is the age, of course, which less than 21 years. It almost doubles the need for intervention. The stenosis, it's up to 2.7 times more than the regurgitation. And finally, the post-implant RV to PA peak to peak gradient. So we have to have a good expansion of the valve. I don't want to proceed with any more data regarding, however, I just want to show you the last slide of this of melody trials, that the safety of melody transcatheter pulmonary valve replacement, as published in JACC intervention in 2018 in 229 patients. After successful implantation, there were no deaths, 5 embolization required surgery arrhythmia, and the pre-catheterization echo RVO outflow tract gradient was associated with the success. MRI anterior and posterior lateral alveolar tract diameters were smaller in implanted versus non-implanted patients, which is something that we should consider. So, regarding the intervention in good patients, we're gaining experience. Nobody can predict exactly what will be the future regarding the percutaneous treatment of patients with GUDS. However, it's a field that it gains more and more attention, more and more experience, more and more costs. And I would like to focus, as the previous speaker has told us, about the cost in the Balkan region. Cost is also a problem in our country, Greece, regarding interventional cardiology, even in GUDS. And I would like to remind you, this is in Greek. However, this is the Kathimerini. It's one of the major newspapers in Greece, and this is this paper was published in 7th of August of 1945. I remind you that in the 6th of August we had the first nuclear bomb in Japan. So this was regarding the penicillin, which was then the antibiotic, which was the only antibiotic that we had, and it was really very expensive. I just want to share with you that the value of penicillin in 1945 was 100,000 for 100,000 units of penicillin was 1,000 drachmas for the rich guys, for 500 drachmas for the intermediate population, and for the people that didn't have any income, it was given without any cost, just free. So I think now penicillin, you can find it almost for free. So I think that all these tools that we're using in interventional cardiology, hopefully sometime will be really cheap for everybody. And I would like also to show you that there is not only good, but also for the we are dealing with every congenital disease in interventional cardiology, and we were really happy a month ago that we had the first international center for PFO training in Athens from interventional cardiologists across Europe. So, Mr. Chairman, ladies and gentlemen, regarding the conclusion, we need in-depth knowledge of cardiac anatomy, procedural steps regarding the intervention in goods pathologies. As transcatheter procedures continue to grow, we have new devices, techniques to address all the good pathologies. Echo and imaging still need to be parallel to be increased, and the organized use of integrated imaging is essential to plan, guide, and assess the procedural outcomes. Thank you for your attention.
Thank you very much, Dr. Constantine, for a very nice presentation. I also hope it very for the sake of our patients that the technology becomes cheaper, so that we can avoid reduced anatomy and dietary complications. And we hope that in time the melody valve will become cheaper and cheaper. One interesting thing was the implantation in native animals, because when we were in the UK, we used to implant valve within valve. So we used to put in a size 21 or 23 Benmount valve, and when the valve degenerated, the melody valve was implanted into that valve. Okay, but I'm now feeling good that the implantation is being done in native animals, and I'm hoping that that can avoid further reduced anomalies. Basically, my one worry was the systematic review you showed. It showed a rate of infective endocarditis of almost 25% in some studies. Why do you think it is like that? The high infective endocarditis.
I can't hear you very clearly because there is sound here, and it's really a problem with it. You asked me about the review, the systematic review regarding
infective endocarditis. The high incidence of infective endocarditis.
the high, yeah. As you saw, there is it's a widespread of the instance of infective endocarditis. I think one of the major reasons is that we don't have a complete expansion of the valve. So there is some part. So we need to have a very good expansion of the valve in order to avoid any infective endocarditis. And we need to take all measures like chemioprophylaxis, everything to avoid this problem. I think for the procedure, we need to have a very well expansion and apposition of the stent.
Okay, thank you very much.